Okay, thanks everyone for coming. Thanks everyone for attending Spine Conference. Today's topic, it's a little bit of a rare one, and I'm sorry, but that's how life is sometimes. We have to go through unusual things, but I think when you go through unusual things, you learn about common things too. So it's going to be on far lateral disc herniations. So who here is wishing for snow this weekend? Me? Yeah, me too. My wife and I love snow. Yeah. All right. So, just 1 second. So I like to go over illustrative cases because we go over people, and then when you learn an illustrative case, you can learn an entire field of medicine sometimes. So this is not the patient herself, but it looks pretty close, don't you think, Aaron? It's pretty. I got that from the internet, so you get an idea what these people look like. I think it makes it funner because it's real. You deal with real people. So she's 54 years old, and she has left sciatica. And she had 3 episodes in the past. The sciatica symptoms are lateral thigh, lateral leg, lateral malleolus. So, Aaron, if anybody ever tells you lateral malleolus, what do you think? Anything springs to your mind? Something springs in my mind like right away. It's like
L5.
L5, yeah, L5. L5. When I hear lateral malleolus, it hits me right in the head. L5. And then when I hear heel and lateral foot, what hits you in the head? S1, yeah. And when someone says knee and medial knee, lateral knee that radiates to the medial aspect of the tibia, what hits you in the head? L4, yeah. And when they say the front of the thigh, what hits you in the head? L3, L2, yeah. So that if you do this a million times over and over and over again, it's a broken record for the spine surgeon, and the patients get frustrated. They say we want to explain the whole thing. I know exactly what's wrong already. So lateral malleolus is L5 nerve root. So that's the first thing that hits me in the head. And this is a problem. She's been to the ER twice, so it's very severe in the last several months. And she's a relatively healthy person, past medical history, hysterectomy. She's a cigarette smoker. She is thin, 5 feet 8 inches, 130 pounds. And the only neurological deficit, other than severe sciatica, straight leg raise, is 4 out of 5 ankle dorsiflexion weakness, which is not too bad. So any questions so far? So left sciatica, 2 to 3 months.
Any history of injury?
No history of injury. So what physical therapy do these patients go through? Who wants to explain that to us? One of these beautiful ladies. Somebody. Christina? I'll pick you because you haven't come in a while.
I know, I haven't. I'm sorry, say the question again one more time.
How do you treat a patient who comes to you with physical therapy with sciatica? Did you take care of these people?
If the physician has felt that there was some, emergency through testing or something that they needed to correct surgically, you look at postural things, what positions improve the pain, what positions make the pain worse, and sort of approach your treatment in that way. Pain relief, those sorts of things as well, but the main approach.
Okay. So here are the X-rays. Aaron, what do you think of the X-rays? Anything? On the left is the lateral view. On the right is the AP view.
Maybe decreased disc height, L5S1.
Yeah, decreased disc height, L5S1. What else? How about just anterior to the vertebral bodies? What do you see?
Say that again.
Just anterior to the vertebral bodies. What do you see? I mean, it's not your job, but you see it.
The artery.
Yeah, the
calcification
of the aorta, which is not good. And we know she's a cigarette smoker, but that's not a relevant issue in this case. Anything else specifically? Look at L4, L5. If you I forgot my pointer. If you look at the framing of L4, L5, do you have one of those? Okay.
In the car.
All right. If you look at the framing of L4, L5, you see, yes, exactly. You see the offending mechanism right there that David showed us. That's the superior articulating process of L4, which compresses the foramen, which is always the offending mechanism of stenosis. And you can see it really well in that X-ray. The L4 superior articulating process in the foramen of L4, L5. So the X-ray is pretty normal. In the AP film, basically no scoliosis. Normal. Okay, MRI scan. What do you see here, Aaron? this is a what? Sagittal cut, right? And the squares are the vertebral bodies. The discs are the cartilaginous material in between. Do you see anything terrible going on?
It doesn't look terrible. I mean, I have L5S1 disc bulge, actually.
Yeah. So the first thing I
2, 3.
First thing I say is there's no fracture, infection, or tumor. Those are serious problems. So whatever this is a degenerative process. So what else do you see?
There are disc bulges, actually 1, 2, 2, 3, maybe
Yeah.
small 3, 4.
At 5-1, 2, 3, 3, 4. So there are many small disc bulges. At L5, the inferior end plate of L5, the bottom square there, there's increased signal in the front. Do you guys see that? What is that? Tumor? Is that where tumor shows up usually? No, right? You don't think it's tumor. Why don't you? You have you know why, but you don't know how to explain it. Why don't you think it's tumor? Okay, there's a very remote chance it possibly could be tumor, but it's not. It's not in the right place. Usually tumor starts more posterior where there's more vasculature. Usually tumor invades through the whole vertebral body. By the time that the patient feels a tumor, it's usually somewhat advanced, so it goes through the whole vertebral body. Usually there's a fracture. So that's just an edema from increased stress at the L5S1 disc. And why is there increased stress at the L5S1 disc? Why is the vertebral body seeing marrow there and increased signal on T2 weighted images? Because the disc's not working, right? So the disc at L5S1 is flat. It's not being the shock absorber that it should be to these vertebral bodies, and now the end plate's seeing increased stress, and at increased stress it's got like a bone bruise, so to speak, or we call it mode exchangers, MODIC, which is the radiologist that first explained it. So similar to what we see in the tibia, right? Do you see this, Doug, in like arthritis MRIs, knee?
Yep.
What do you tell patients it is?
Bone bruise that lasts 4 months.
Okay.
If it's acute, if it's degenerative, then it's lasting forever.
Bone bruise, yeah. So that when that first came out with football players, remember we said nobody knew what it was and the significance, but now it's part of our world.
Everyone gets an MRI.
Everyone gets MRIs for everything. Yeah. So, okay. So here's another view. Now again, sagittal cut, and anything specific here? Did you see, Aaron? What are we looking at? What in our minds? What's percolating in our minds with this patient? Because we're not radiologists, we're
We were already
clinicians.
looking for L5.
L5, right? So where's the L5 in this MRI? You can see it. It's on the right.
Right.
Yeah, and it's in the.
Sorry.
Yeah, it's on the right. It's in the framing, which is right here. Okay. So that's the L5 framing, and that's the nerve root. And looks normal. This is the pedicle right here, right above it, and this is the other framing. So, so pedicle and framings, and nothing's really compressing the L5 nerve root, right? Parasagittal cuts. So let's keep going. Anything? You see anything in the L5S1 framing again? Here's the L5S1 framing again. Right there. I have to stretch. And here it is on the other side. Right there. Do you see anything? No, right? How about here? L5S1 framing again. Here and here, two views. So here and here. Now these are sequential sections. Do you see anything that could be hitting the L5 nerve root?
Maybe on the
Yes.
right.
You think that's compressed? Maybe, rather, maybe. So what about the marrow changes about the L5S1 disc space? Here and there. See that? Does that look like marrow changes? Looks like it, right? So that's a better view of the parasagittal cuts. So here's the next view. Again, we're looking specifically for in the framing here and here, which is here and here. Do you see anything that may look abnormal?
Yes.
What do you see?
On the right, looks like there's disc material.
Yeah, the right may be stenotic, but on the left, do you see how the color is different from the disc? You see how this color is different from that color? You see that? So in the front of the disc, it's all black, and on the back of the disc, you see that little ball, and it's got a different color to it, right?
Mm-hmm.
What do you think it could be?
Nucleus pulposus.
Yeah, exactly. Nucleus pulposus. And why does it have a different color? Any guess?
Consistency,
Different density.
density.
Yeah, different density. And nucleus pulposus, from anybody who knows the jelly donut analogy, what is the nucleus pulposus like?
The jelly.
It's like the jelly, yeah. So it's more water, it's filled more with water. So that very likely could be our problem. Okay, so this is an axial cut. So that's all of our sagittal cuts. So we're a little suspicious, right? We saw something in the very outside corner there which may be abnormal. So this is at L4, L5, and I wanted to show you this is normal. In the center you see the spinal canal and the foramina are totally open, and on the front there are the discs, and the spinal canal is normal, and the dots are the nerves. So the dots are the nerves, this is the spinal canal, this is the foramen with it exits, and the black thing is the disc space. And that's at L4, L5, and that looks totally normal. Now, for extra credit, who can tell me where the L5 nerve root is here at L4, L5? Remember, the L5 nerve root starts in the brain and runs all the way down the spinal cord, all the way down the conus, all the way down the cauda equina. It exits at the L5 pedicle. It goes to the L5 S1 foramen. It goes to the front of the sacrum. It enters the psoas muscle and the pelvis. It's next to the uterus as it coasts down. That's why some women get L5 radiculopathy from tumors, from sarcoma in the uterus, and then it goes down the back of the leg and the sciatic nerve, and then it exits at the level of the fibula. It goes down the perineal nerve. So it's got a long track, the L5 nerve root. Can you find it there? For extra credit. So it's right there. It's right here. It's in the spinal canal. It's in the lateral portion of the fecal sac, and it's starting to exit. Okay, so if someone's super smart, who can tell me where the S1 nerve root is here?
Just medial to the L5 nerve root.
Yeah, I would say right there. I would guess that's S1. Okay, and who can tell me now where S2 is in this image? Which direction?
Below it.
Probably right in there. S2, S3, S4, S5. So this is where the sacral nerve roots, and they're all there, and they all run down. So the point is, you have to always think of this as a surgeon, because if you do an operation and people don't get better, they're really angry at you. I mean, they're furious, right, Doug? So we have to be sure what we're doing. There can't be so much guesswork. So any of these areas can be compressed at any point in time. Now at L4, L5, why is it that you cannot get an S1 radiculopathy? Anybody guess? At L4, L5, where we're looking at right now, why is it you can't? It's impossible almost to get an S1 radiculopathy. It's very, very difficult.
Because the nerve root hasn't exited yet.
Look where the nerve root is, in the very middle of the canal. So you'd have to obliterate the entire canal to get it. So there's no way to focally hit S1. If you get that, it does happen, but then what does the patient present with? If you have a big disc herniation or a tumor that is so big to compress the S1 nerve root, how does the patient present? Cauda equina syndrome, yeah. So all the nerves are compressed. So it's a totally different picture. It's not a focal S1 radiculopathy, but it's loss of bowel bladder control, perineal anesthesia, legs are terribly painful and numb. So that's why this is not relevant. But I think it's fun as a surgeon to know where everything is. It kind of makes life fun when you understand things. In general, I think so anyway. So here's now we're tracking down the axial spine, and this is at the level of the pedicle of L5. And I've circled the L5 nerve root, and it's exiting the foramen at this point. Does it look like it's being compressed at all? And on the outside of the, right here, on the outside of the pedicle, right there, there's a structure. Now what smart person here can tell me what that structure is? We're at the level of the L5 pedicle.
Iliac artery.
No, but I like the way you try. You're like a fighter. Keep trying. Keep it up. I like that. I say it to my kids. Just do something wrong. Just anything, but do something. What else? Who else can guess? It's a nerve root, so it's already exited. It's a nerve root that's exited the spine. L4, yeah. So that's L4. So, Aaron, how can we hit the L4 nerve root during surgery? Just think of mistakes we make. Not me, but other doctors. Huh? Go ahead.
With a screw?
Yeah, very easily. So if the screw is lateral here, which happens, that can hit the L4 nerve root. So when patients come in, they say my L4 nerve hurts, and you look at the L4 screw, it looks fine. Well, it's not the L4 screw, it's the L5 screw because it's lateral, it's hitting the nerve there, and that's possible. But what's different is why it usually doesn't happen is the nerve's got plenty of space out here. It's in the retroperitoneal space, so it's usually got a lot of room to move, but not always. So this is something you have to consider as a spine surgeon. Okay, so we're down another level, and I've circled it here on the left. You can see the nerve root on the right easily, right? You see that little dot by the R? But on the left, you can't see the dot, and you see this big thing. What is that?
That's the nucleus pulposus.
That's probably, yeah, that's probably a nucleus pulposus out there. What is it doing out there? Why would nucleus pulposus be out there? Isn't it supposed to be in the spinal canal?
Just
Right?
to make you mad.
Just to piss me off a little bit. Why? Because you know the disc doesn't have rules. Like the disc doesn't read our books. The disc goes wherever it wants to go. So the disc can go into the belly. The disc can exit any point in the disc space. It can be the front, the sides, whatever. So it just chose there. So why are we so focused on disc herniations in the spinal canal as human beings, as surgeons?
So painful.
Yeah, those are usually the patients we see. But the disc can go anywhere. So when it ruptures in other places, it's asymptomatic. But this one is symptomatic out here. And we'll go over that. How about here? What's the circled thing here?
The herniation.
More disc. And you can see on the right side of the spinal canal, which is on the opposite side, you can see the little circle where the nerve root is, but you can't see the nerve root where the big circle is, and that's because there's a far lateral disc herniation. You can see where it is at L5S1. And again, that's the L5 nerve root. You see it on the normal side, and you see a little circle, and on the other side you can't really see it because it's compressed by this disc herniation. And this is outside of the spinal canal. And this is the L5 nerve root now. It's free, but we're a lot lower. So that's where the L5 nerve root sits on the sacral ala, and then farther down you can see where the L5 nerve root sits on the sacral ala. So you can hit that too with all sorts of things during surgery, or some disease processes can hit it. Like usually it's uterine carcinoma can hit the nerve root out there, or sarcomas when they get really big. Okay, and here's another view. And who, for extra credit, who can tell me what this one is right here? And this is L5.
That's one.
That's S1, yeah. So that's hugging the sacral pedicle, which is a really big pedicle. The sacral pedicle is massive, and that's S1, that's L5. And Aaron, this one for extra credit?
Two.
That's 2, yeah.
3.
And 3 and 4. The nerves that go to our bowel and bladder control. Here's just another view. Now in the sacral ala, you can see all the nerve roots. Okay, so what this is let me do a poll. What do people feel about deer here? Hate them or love them?
They're cute.
Cute?
They make my dog run away.
Yeah, my dog hates deer. I don't like deer. They get on my nerves. Okay. So this is a far lateral disc herniation. There's another, in medicine there's always multiple terms. It's also called an extraforaminal lumbar disc herniation. It's not a normal place. It's not in the spinal canal. It's not in the foramen. It's outside. So it's a far lateral disc herniation. It's less than 10% of all disc herniations, and also it's even more rare at the L5S1 junction, probably because L5S1 doesn't have much motion there. It's usually at L304 and L405. It's near the dorsal root ganglion, and that's why it's so painful. I'll go over that in a second. And it's most common in the 6th decade of life. So our patient, she's 54, so she's, that's 5th decade. I always mix this up, right? 6. She's a perfect patient. 6th decade of life. Why, I don't know. So what's the dorsal root ganglion? The dorsal root ganglion is dorsal. It has sensation. It's right here, and it's a very, very sensitive place in the nerve root because it has all the pain fibers. So any disc herniation in the foramen or any disc herniation that's outside the foramen is extremely painful. And these patients, when you see them, you think, boy, this patient's insane. I mean, this cannot be that painful. Well, no, it is. It really is painful because it's on the dorsal root ganglion. So it's an especially very painful process. So this is a schematic of where disc herniations are. The squares are the vertebral bodies. The little circle in the square is the pedicle. And these are nerve roots. So if you have a central disc herniation that's really sharp, which is very rare, that can hit a nerve root that's not really correlated with that vertebral body. Now most disc herniations are right there, which is hits the nerve root that's traversing that segment. And the nerve root that exits, this is the exiting nerve root. The exiting nerve root's is the foraminal disc herniation. So what color is this thing? I don't know. Is that yellow?
Yes.
So the yellow one, yeah, the yellow one is a foraminal or extraforaminal disc herniation, and that's how our patient is presenting. So this schematic is more important if you're a surgeon, so you know what level you talk about. So I think you have to understand the relevant anatomy. It's very important. The squares are the vertebral bodies, and you see in the middle of the vertebral body you have the basovertebral vein. There's very big veins there in the vertebral body, and you only know this if you take these vertebral bodies out during surgery. They bleed like crazy. And also these veins are where what importance do they have in like tumors?
A tumor can travel along them to
Yeah.
distant sites.
Yeah, so
Batson's veins.
yeah, Batson's veins, right. So that's where the tumors usually start and lodge. So if you catch an early tumor, that's where you're going to see it usually. And the vertebral bodies, they're not sloppy. They're held together by ligaments. And in the front, it's called the anterior longitudinal ligament. On the back, it's called the posterior longitudinal ligament. And there are other ligaments too, but let's just focus on these two. So the anterior and posterior. These ligaments are really strong. So if you tried to like break a spine with your hands for some reason, you can't tear the anterior longitudinal ligament. The bone will break before those things tear. They almost never tear. It has to be a very, very violent injury. So if the anterior longitudinal ligament or the posterior longitudinal ligament is injured, those things get injured like a very severe car accident, and the patient usually suffers a paralysis with those type of injuries. So now let's look at the posterior longitudinal ligament. So there's the anterior and there's the posterior. Now the anterior is a lot thicker. You can see that on the right than the posterior. And in the posterior, the ligament has a definite shape to it. You see the triangular shape of the posterior longitudinal ligament, and it's thin right here. You see how it's thin? So remember I told you where most of the disc herniations are? So why are most of the disc herniations right there?
Because they can't push through.
It's a weak area. So that's a relative weak area, the posterior longitudinal ligament, and that's why they usually herniate there. That's why they don't usually focally herniate through the posterior longitudinal ligament direct central, although they can. Also, the other important aspect of this is the interspinous ligament. So you can see the interspinous ligament right here. It connects the transverse processes, and that's relevant to this case because we have to open that during the surgery. So any questions so far? So this shows you where the dorsal root ganglion lies, right in the foramen. And if you get a foraminal disc herniation, this is cervical, but same thing. If you get a foraminal disc herniation, it hits that dorsal root ganglion, and it's very, very painful. Yeah, very painful there. So this is the model in my office. So the patient failed non-operative measures. Let's just leave it at that. And she needed this thing fixed. We put her on medicines. We offered therapy, all sorts of things. She goes, no, please just cut this thing out. I can't take it anymore. So this is a model in our office, and it shows you the L5-S1 posterior view, and it shows you where the problem is. It's right here. It's right there. Okay. So it's very deep in the body, and it's next to the. It's not a typical surgical view. So this shows you exactly where the problem is, and you have to look from the front to really see it. It's right here. It's right there. So here's the hole, the foramen where the nerve goes out, and this is the sacral ala next to it, And the disc, you can see where the disc is. The disc has traveled and is compressing it there. Sort of, it's very deep. It's deep to the sacral ala from a posterior view. So here's a posterior view. You see the sacral ala. It's deep to that because it's deeper to the intertransverse ligament. So it's a very deep place to get to. Now, luckily, I think like 15 years ago, it would have been hard before the advent of microscopes. But now with microscopes, I mean, I don't know how to explain it to someone who doesn't do microscopes, but 20 years ago, the microscope was kind of like a Chevette. Anybody here drive a Chevette? You try to drive a Chevette quickly, and it doesn't work so well. I used to have a Chevette. But now it's like kind of like, you know, a Mercedes or a BMW, and it's incredible now. It's a difference between a Chevette and I would say a Mercedes. I don't drive a Mercedes, but if I did, I'm sure that's what it would feel like. I assume it's a lot better than my Pilot. So this shows you, now, here's the hole where our disc herniation is, right in here, where all these ligaments attach the pelvis to the spine. So you can see there's a lot of things there, and they're very strong structures. So how is that relevant to us? Like, who cares? Like, why is that important? Why is it?
Well, if you had to interrupt them, it might cause some instability.
Right. It can cause instability, which is always in the back of my mind. And also, it's like a tunnel. So it's like it's a really small space because of all these thick ligaments. So the nerve doesn't have that much room in there. So the addition of the space-occupying lesion of the disc fragment, that's why it's a problem. It's a small space, basically, especially at L5S1. So to get to this, you need to do a Wiltse approach. Wiltse was a surgeon who did most of his work in Southern California. And for orthopedics, he's sort of like a pioneer educator. He was an incredible man and a very good surgeon. And he did a lot of work with spondylolisthesis and work in the pars area. And he sort of championed or explained this approach where you don't go direct central, but you go somewhat to the side. And it's a lot easier to get to the foramen. And this is the approach you need to do for these cases. So this is the model in the office. And the disc herniation is right here. So that's the disc. And these are I know this may be a little boring, but you need to know this for the video. This is the transverse process of L5 right there. And on the other side is the sacral ala right there. And then on the top is the facet. Because the facet is made up of S1 and L5. So the disc herniation and the L5 nerve root is right in the middle. So I drew this up for you guys today so you understand. So the transverse process of L5, and I circled the pedicle because in your mind's eye you should know where the pedicle is because that's how you can find the nerve root. And the pars area of the lamina, and then the nerve root's deep to that. And you can see real super deep is the disc, and then on the right is the sacral ala. And you can see the facet. So it's a very small, deep area. And the first order of business is you got to find the nerve root. So any questions about what's going on? So you can see where the disc herniation is compressing the L5 nerve root out there. Okay. So any questions? All right. So the next step is we're going to roll the videotape. Just give me a second. Okay, welcome back. So this is so I'll put some music to it just for your pleasure. So you can see here's a transverse process of L5. This is the pars. Remember the model we talked about? And the sacral ala is here. So in surgery, I mean, everybody does things differently. But I don't do anything until I know exactly where everything is. And if there's a question in my mind, it really, really irritates me when I'm not sure of something, when I'm not sure where something is. So I take extra time to be sure I know where everything exactly is. And then sometimes that's not possible. So sometimes I don't know where something is, and that bothers me the whole case. Like I'm always thinking we don't know where the nerve is, or we don't know where the pedicle is, or I mean, David, do you do the same thing? Have you found that when you were in surgery?
Right.
It's like it's always like you always want to know where everything is, and when you don't know where something is, that's on your mind the whole time. So this part of the procedure, so I've got the transverse process, I've got the pars, I've got the sacroiliac, I'm looking for the nerve root, and this I burred down the pars area a little bit, and I removed some of the pars, I removed some of the transverse process, and I removed some of the sacroiliac just to open the hole because it's a very small hole. There, that's the curette. Teasing off all the soft tissues deep, because remember the nerve root and the disc is deep to this area. So the other thing that you guys know, I know you're not spine surgeons, but whenever you get these disc herniations, it's been there for how long? Like 3 or 4 months, right? So the whole thing gets scarred. So you have to tease off all the scar off the nerve root. So that's so I'm teasing everything off the transverse process, try to find the nerve, and I know the nerve should be right in here, but I can't see it. The other thing is the intertransverse ligament is there, so I sort of have to peel that away. And there's also muscle there that bleeds. So this whole thing is looking for the finding the nerve root. So I'll show you the nerve root. 5 minutes later, I finally find the nerve root it felt like 3 hours, but it was only about 6 minutes into the case. But for me, it felt like 3 hours. So the nerve root lays right in here. And I tell Aaron the nerve root looks like a thick piece of spaghetti, and it's white. When you guys see this, you're not gonna be amazed, because you don't see it very well, because there's always this bleeding. But the nerve root lays right in there. So I think, see, I keep teasing off all the scar. Let me just give it a second. You'll see a glimpse of the nerve root. Not really. Well, you'll see it. Hold on, I'll show it to you in a second. I also I removed some sacroiliac too. So remember on the right is a sacroiliac. So that with the kerosene, I'm removing some of the sacroiliac because the disc is just above the sacroiliac. So to be able to see everything, I had to remove things. Basically, I'm opening up the hole. And no, it's not good to remove these ligaments, and it's not good to remove some of the sacroiliac, but it's usually not a big deal. It's usually people can live with it. So I'll show you teasing out the root. It's at 17. Okay, so I've seen the root at this point, and now I'm teasing away the disc material from the nerve. The nerve is right here. Let me show you. Hold on. So between here and here is between the disc and the nerve root, and that's sacroiliac. So that's a nerve hook, and I found the nerve. It's right here, but it's covered with veins. So I don't want to disturb that. All that's going to do is bleed, and it's not good for the nerve root to remove its vascular supply. So once I find it and I know where it is in my mind's eye, that's enough for me usually, and then I proceed. And that, I know you guys can't see it, but I know where it is, so I don't have to see it all the time if I know where it is. So that's how surgery is. Did you agree with that, Doug? Like when something's in your mind's eye, then you're good, right? I mean, so what I'm doing now is I'm trying to find the disc material. I found the nerve, and I'm trying to find the disc material, which should be just deep to the nerve. I'm teasing it out. So let me go show you the disc material. So I'm just stopping the bleeding so I can see a little better with wax. That's okay. So it should be, yeah. Okay, so trust me, you're gonna see the disc material. So the nerve is right there, and there's these blood vessels that are basically just hampering the procedure because I can't see. So I'm just stopping the bleeding. These little blood vessels that are mostly in the musculature of the lumbar spine and around the nerve root. Can you see that white thing right there? That's the nerve root. You can see it well right there. So I'm kind of peeling everything off the nerve root. See that? So you just barely see the disc right there. The disc is right there. So there's the nerve root, and the disc is right deep to it. Just give me a couple more minutes, a couple more seconds. You see that white stuff right here? See it right there?
Mhm.
So that's the disc material right there, and this is the nerve root.
Huh.
So now on the MRI, it just looked like a little blob, right? But during surgery, it's got all sorts of different shapes sometimes. Sometimes it can be hard, sometimes it can be soft, sometimes it can be stringy, sometimes it's one big piece, sometimes it's many small pieces. It's very different. The MRI just basically tells you where the problem is. It won't tell you what you're going to find. So you're going to see the disc in a second. So it's just bleeding. So the bleeding kind of hampers my view. So I'm trying to get these vessels. So right here over the sacral ala and through the transverse ligament, there's all these blood vessels. So I try to do the case without doing this, because it's just when you coagulate near the nerve root, there's always a chance you may cause a problem to the nerve. But sometimes you just have to do it. So at this point in the case, I just said I gotta bite the bullet and just get these veins. Otherwise, it's going to really hamper me. So I coagulated as many of them as I can. And then once you stop the bleeding, you come in with a pair of scissors or a knife, and you just basically cut the veins like that. And then once you cut the veins, then you can spread the veins apart. See that? So it's kind of like a standard thing in neurological surgery. It still could bleed after that, but usually it doesn't. Now you see the nerve's right there, the disc material's right there. So I'm basically trying to lift the disc. You see the disc coming out? Now that thing looks like it's under pressure, right? See that big white thing? And the pituitary pulls it out.
What?
See, that's the nerve right there. Yeah. Isn't that shocking?
The whole disc? Or just that part?
That was just a piece. But that was pretty impressive, right?
Yeah.
Yeah. And you can see how, like in the MRI, you weren't that impressed the whole hour. You're like, how can this be a problem? But when you look at the microscope, that's a problem. So now this poor woman is vindicated. I mean, she had a problem. You see more disc materials coming out. So now I have to be sure that I got it all out and I have plenty of room, so I'm palpating the nerve and seeing how free it is. It should be nice and free and loose. And once the other thing about nobody taught me is, like, once the disc material is out, the anatomy is a lot more normal, because when the disc material is in there, everything's tight and abnormal. But once the disc material is out, then it's very clear where the nerve is and where it should be. So it gets a lot easier to dissect after the big fragment's out. There's still some more disc material in there. You see it right there.
In the future, will more disc squeeze out? too?
Possible. So 1
Yeah.
out of 20 people.
Mhm.
But you can see this is a very tight space with a lot of ligaments, a lot of muscles, and it's a tight canal. So that's why these things happen. That's why see that there's more disc material right there. So I'm trying to peel it out, like lift it out, basically. See how it comes out? It comes out with the sucker too sometimes. See how more comes out? So it's all sitting right on the nerve. You see the nerve is right there. You can see the nerve well now. See that?
Yeah.
See, that's right next to the nerve. And it's really compressing the nerve. And again, this is a sensitive part of the nerve too. So it's not only neurological compression, but it's in a bad place. See how more disc material comes out? And then this is always the problem during surgeries, like, when do you stop? Like, do you stop when you're tired? Do you stop when nothing more comes out? Do you stop when, like, I don't know. I asked Erin, like, Erin, is that enough? Can we stop now? She never answers it, though. She's just silent. She's kind of, Erin's kind of like God. I just ask questions, and there's nothing there. It's just silence. So that's basically the whole case. So now I'm just looking for more disc material.
You felt better right away after surgery?
Yeah, immediate. Yeah. Okay, we'll show the disc one more time. So there's the
Does
disc.
the patient have some pain due to edema of the nerve because of all this manipulation?
Does happen, yes.
No, I was gonna ask that.
No.
Does happen, yes. And that's the other thing, is I'm manipulating this nerve the whole time. And people, sometimes they have worse pain after surgery, usually not, but sometimes they do. And those patients, I give them Decadron, and it goes away. It's just an inflammatory process. But that does happen. Okay, so any other questions?
There is no peripheral nerve approach in the sense that you could interrupt pain fibers and leave the sensation intact. There's no way of doing that, is there?
Just
Rather
cutting,
than getting into the nerve root.
doing what?
Well, I mean, the problem for this lady is that she has pain.
Pressure on the nerve.
Yeah, the pain fibers.
Yeah.
So there's no way of eradicating pain fibers and leaving everything else
It
intact.
never works. So
No.
I mean, that in this case, this is not a case for that. But let's say a case like Doug, what do you think of that? So let me ask Doug the question. So let's say you have a really painful like sural nerve in the foot. That's a better
Yeah.
instance. What happens when you just cut the sural nerve? Does it work? I have my own theory. I think the thing grows back after a while, and it's even more painful.
Well, some people injected it for diagnostic purpose. You know, if you can numb up the nerve and it gets rid of the pain, then people say, that's why you have pain, and you're not crazy, or it's not something else. So, and some people are
With
doing-
lidocaine, you mean?
Yeah.
Okay.
And some people, I have a lot of people come to my office and, he burned the nerves or something. I'm like, really? But there's some people that are doing.
Well, you know what that is, right? That's the pain management people when they burn the nerve that goes to the facet.
Right.
Yeah.
Right. So, there are probably someday in the future there'll be a way where you can put a robotic needle in there or something and extract the disc or something.
No,
But
but it doesn't work though.
The pain fiber will
These-
mingle with the other sensory nerves.
They grow back. These thin
Yeah.
fiber, they call it C fibers.
Yeah.
These thin fibered pain fibers, they grow back.
Mhm.
So it doesn't work well. So the other thing is pain doctors do that. They inject alcohol
Mhm.
and into like the plexus and all sorts of places. They do that, and they kill the nerves that way. It's usually temporary. I think they grow back.
Mhm.
So the other thing is like in spine, you're like, why don't you just look when a disc hurts? Why don't you just denervate it? Why don't you just remove all the nerves to it? That should take the pain away, right? I mean, I think it does work temporarily, but I think these nerve fibers come back.
And having absent sensation would be a handicap.
My wife had a medial branch
Somewhat.
ablation of her nerves, and pain came back within 6 months.
Yeah.
I think they grow back. And the other theory I have is like non-union pain. So when you do a fusion for something that's painful and you put screws across it and try to fuse it, the patient has no pain for like a year. And then the pain comes back and you realize there's a non-union. So why is the pain not there until, like, you find out with fractures, don't you, Doug? So let's say you have a tibia fracture. You nail it, patient's fine, they're walking around, they feel good. And then the non-union pain usually comes back like 9 months to a year. You get an x-ray and there's an obvious non-union. But that thing never healed in the first place. So why is it that the pain came back late, like much later?
Yeah, you
Like,
get initial stability from surgery.
yeah, but why does the pain come back 9 to 12 months? I have a
You
theory.
get initial stability, plus you also decompress it. If you take the periosteum off it,
It's still just as stable.
we're going with your theories now. Huh?
My theory is that that's when the pain fibers grow back. So it takes 9 to 12 months for the pain fibers.
So, like in foot and ankles, a lot of podiatrists will inject Morton's neuromas or interstitial nerves with alcohol. And I see a lot of people that say, I have 18 of my nerves injected. You got to inject this one.
Yeah.
It's very difficult if you're doing it with a needle with some type of alcohol or something to figure out how much of a nerve you're killing.
Yeah.
Huh.
But it always comes back. So I think the pain fibers grow back in 9 to 12 months, and that's why it doesn't work very well.
Certainly the sensory fibers don't come back like that, though.
But I think the pain fibers do.
Yeah, but if you operate on someone and you get an area of skin anesthesia, I think they'll always say that their anesthetic there tends to be less symptomatic. It's like, it's just a numb spot now, it doesn't bother me, but I don't think that, you get a little bit of reinnervation, but I'm not sure if they ever get complete reinnervation. And it's probably the same with pain. You probably get a little bit of pain fiber regeneration, but I'm I'm not sure if it's ever complete, you know, and to address Alan, Spiro's sort of, putting lipstick on the pig, he says that, he cures this, but it's a degenerative condition, so 5 or 10 years down the road, they're gonna get something else with probably at that same level, right?
I wouldn't say lipstick on pig. I'd rather say a rosy picture. I paint maybe a rosy picture.
Cured them.
But I think it's
Took
part
that
of the
appendix
human.
out.
No, I tell people it's part of the human condition
Yeah.
that we're not designed for immortality. I mean, but not everybody. I mean, some people like this, they go for the rest of their life, never see them again, they're fine. We see patients like that all the time.
Right.
But there is a subset of people that just keep deteriorating that level until you fuse it.
Or adjacent level.
Yeah, and some people just keep deteriorating. They're like this. Their whole body just wears out. I mean, you see that in orthopedics. You see, you fix one knee, and then the next knee becomes a valgus knee, and you replace that knee, and then their hip gets extremely arthritic. I mean, there's some people that are just deteriorate.
Could you remove a good share of the disc anteriorly and attain this result, decompression? Because you're avoiding all these deep structures, and I would think that you could remove most of the disc and then a plate and screw, or
Not
could.
when it's extruded out the back, though.
but
You
this
could, but-
this is lateral. You said.
Yeah, you
See,
could do it
you're
anterior.
not going posterior. You're going laterally.
No, you could do it. It's really hard though, because it's really, really
More
deep.
difficult than this.
Yes, because the belly's really deep. So think about a pelvic tumor. That's a deep hole.
Yeah.
So that's even deeper than a pelvic. This is even deeper than a pelvic tumor. And the angle's really hard because the pubis gets in the way.
Right.
So think about, I mean, I'm sure you've taken out like a bladder cancer. Those are deep cases.
Mm-hmm.
So this is even deeper than that because you're like past that into the spine. I mean, I've done it though. I've taken
A
out.
lot anterior to the spine, right?
Yeah. So I've done that. I've taken out an epidural abscess from
Now,
a
do
front
these
side
occur in
approach.
the neck? I was thinking. How
In
about
the neck, it's a piece of cake because the neck is small structure.
Yeah, you could do that anteriorly.
Yeah, I mean, look at someone's neck. I mean,
Yeah.
the neck is almost like an arm, but the trunk is really thick. So that's why interior is very easy in the neck, but very hard in the belly.
Yeah.
So, but you can do that, but then you fuse it. Then you have to fuse the level, like you
Right,
said.
right.
I've done that before. I usually do that with infections because the whole disc is infected. You have to take the whole disc out and then replace it with allograft. It's best done through an anterior approach. But I don't see that many cases, really. We don't have too many. I used to see those at university, and they're usually intravenous drug users because they tend to get these infections. Okay, so any other questions? Yes, Dr. Davis.
All that part of that lady's disc that you're pulling out, that was still attached to the
It was.
disc.
Yeah.
Sometimes it's free floating body.
Yes.
Some
You saw some of the pieces were free. Some of it was a stringy long piece. Some of it looked soft. Some of it looked hard. There's no way you can tell what it is from the MRI. Remember, the MRI was
Yeah.
just a blot with a dot.
huh?
It's supposed to look like crab meat.
Huh.
Well, we're from Maryland, so we always say.
Well, in New Haven, they said crab meat. You go, yeah,
Did
taking
they?
that crab meat out makes you feel good. Doesn't do anything for the patient, but it makes you feel really good.
Yeah, I say crab. It looks like crab. People in Maryland, they like that. Ooh, I like crabs. Really? All right, any other questions? Okay, thanks everybody for coming.
Thank you for the comment.
See you next month.
That was good.
Picky point.